Thank you again for the opportunity to be involved in your conference. I'm going to talk now about the role of molecular biomarkers in prostate cancer diagnosis. So we do have an unmet need for a better prostate cancer diagnosis strategy, and the hope is that the use of biomarkers will allow us to reduce the number of negative biopsies. The goal would be to have a situation where by the time we come to biopsy a patient, we are so sure they've got prostate cancer that there's almost 100% diagnosis rate for significant cancer. This would be a marked improvement compared to the current situation where the positive predictive value for a positive biopsy is only about 1 in 3, and the majority of patients have negative biopsies. This would also reduce the rate of overdetection of clinically insignificant cancer. And of course, fewer biopsies means fewer complications. I mentioned earlier in my previous talk that really Gleason pattern 3 is more of a pseudo cancer. It has no metastatic potential. We don't really want to diagnose this disease. And this is some of the molecular genetics behind the recent development of molecular tests for higher grade prostate cancer. And the key point is that grade group 1 cancer in almost all cases does not have significant molecular aberrations. This study defines something called the average genomic risk, the AGR, which is a metascore of genetic aberrancy and aggressivity. And this is from favorable genetics on the left to very aberrant genetics on the right. The second line is the Gleason score. So you can see it goes from light blue to dark blue. There's a few light blue cases in the highest risk category, and overall about 2% of grade group 1 cancers are in this highest AGR quartile, in other words, the worst genetics. Now, as soon as you have elements of pattern 4, there's a 7 times higher rate of severely abnormal molecular genetics. So Gleason 3 and 4 are really like night and day, and this provides the opportunity for a liquid test, a liquid genetic test to identify whether higher grade cancer is present. Now, the first area I'll touch on briefly is germline mutations in DNA repair genes. So I think everyone is familiar with this now, the BRCA2 story. But just to emphasize how important this is, at the bottom you see the molecular pathway for sporadic tumors. And the key point is it is a long, slow process. So you begin with loss of some key tumor suppressor genes like P53 or P10, and then over time you have acquisition of other abnormalities, gain of some oncogenes like MYC, you get more genomic instability. But it takes typically 10 or 15 or even more years. In the patient who's got a germline mutation, it's very rapid, right at the beginning. As soon as you get the first alteration, there's this explosive acquisition of genetic aberrations. And if you are counting on a patient remaining stable on surveillance for a long time, this is a bad strategy. We now have some clinical data on this. This is a study from Hopkins that compared the likelihood of progression in men with DNA repair defects to those who were normal. And you can see at the bottom left, the hazard ratio in the BRCA2s for progression to higher grade cancer was almost 3 times greater, which meant that almost 100% of men by 10 years on surveillance had progressed to higher grade cancer. The figure here is about 80%, but it's likely that they missed the other 20%. So men with BRCA2 mutations particularly should not be managed with surveillance, in my opinion. Now, how do you identify them? It's gotten quite inexpensive to do these tests now. This test is available anywhere in the world. It's an online application. For the more comprehensive tests, it costs $250 US. And the patient gets a kit and he sends some saliva back in a test tube and he gets their result, including all of the BRCA mutation results. So, of course, usually it's negative, and this is tremendously reassuring to the patient to know that he's not either inherited genetic defects or can't pass it on to his family members. And if it's positive, of course, it's very powerful because it has implications for everyone in the family. So we have the patient with elevated PSA, and then the question is MRI or biomarker, and there's pros and cons of both. So the biomarker doesn't require interpretation. It's standardized. It allows risk stratification. It's often cheaper, and there's no issue about limited resources. The MRI, of course, gives an image, which is very powerful for us as treating physicians, but it does have some of these other limitations, and the price is coming down. This is a summary of the commercially available biomarker tests to find significant prostate cancer. And these are in blood, like 5 and 4K, in urine, the MIPS score, the Select MDX, which is looks for gene expression, RNA expression in exfoliated urine cells. ExoDX looks for urinary microsome microRNA. And then you have tissue-based assays that microdissect the cancer that's seen on the biopsy and look at their individual gene expression. The cost varies from about $500 for the liquid biomarkers to around $4,000 for the tissue biomarkers because they're quite labor intensive. And the area under the curve is somewhere between about 0.75 and 0.90. I emphasize none of these tests yet have been compared to each other on the same patients. So these are different populations of patients, and I think you need to therefore compare the area under the curve with caution. But at this point in time, the Select MDX test looks like the one with the highest area under the curve, and I think it's the most widely used, at least in the United States. There's others that are coming. A number of these, TELO-PC is a telomere assay, MITO-PC is a serum-based mitochondrial deletion assay, a free DNA assay. I'm going to talk briefly about this Sentinel assay from Mir Scientific in a moment. Let me just make one comment about the tissue-based biomarkers, and that is I think they have a major challenge, aside from the fact that they are expensive and labor-intensive. And that has to do with the genomics, the heterogeneity of cancer genomics in prostate cancer. So this is a very interesting study that took 41 patients, all of whom had multifocality. On average, they had about 4 individual cancers. They did whole exome sequencing on each cancer from these patients and looked to see how many of the genetic aberrations were common to all the cancers and how many were unique. And the disappointing observation, and other groups have reported exactly the same thing, is that about 95% of the mutations in an individual cancer are unique, the gray ones. The orange ones are the common mutations. So you take a patient who has a biopsy, you send his Gleason 6 core off to the company, they microdissect the core and tell you what the gene expression is. It doesn't mean, in fact, the likelihood is that those are different genetic alterations than exist in the other cancers in that patient's prostate. And this is one clinical study published recently that confirmed this. This is from the Canary Group on the west coast of the US, adding the Oncotype DX or GPS to the PSA density and diagnostic Gleason score didn't improve stratification. So I think we're moving to an era based on the liquid biopsies that's going to simplify screening a lot. We're going to take patients with a fairly low cutoff of 1.5 or 2. That group with PSA lower than 2, say, has a very low risk of significant prostate cancer. The others who have a higher risk, doesn't mean they have the disease, will go on to a second test like Select MDX, and then perhaps imaging and then biopsy. So by the time the patients get the biopsy, they have a much higher risk of being found to have significant cancer. And there's a number of serum, urine, protein, DNA, RNA that can be evaluated. So many options in this area. I'm just going to speak briefly about one that I'm very excited about called the Sentinel assay, which comes from Mir Scientific. This is not yet commercially available, but it will be soon. And what it evaluates is the microRNAs or non-coding RNAs from urinary exosomes that are shed in the thousands per day by each prostate cancer cell. And there's more than 10,000 of these non-coding or regulatory RNAs have been described. And what they did is picked out, looked at the predictive value for significant cancer of each one of these thousands of non-coding RNAs and selected 440, each one of which had predictive value. So what you see on the left here is the relative importance or predictive value for significant cancer of each one of these sequences. And when you put them all together, so these are assays based on sequencing about between 200 and 400 microRNA sequences in the urine. There's no DRE required. And you look at the area under the curve. This one is for any cancer. The one on the right is for grade group 2 or higher. Area under the curves that are really significantly superior to what we've seen before, 0.96, 0.97. This has been published in the journal Urology within the last 6 months or so. And I think we're going to be hearing more about this. And this gives you a real sense of what the future could be. And once we have a very reliable biomarker, I think it'll change how we manage patients quite fundamentally. This comes from the hematology literature, the idea of dynamic risk profiling. So you just follow patients with the urine assay over time. And if, say, after 5 years, the assay converts from negative to positive, you have a reliable signal that the patient should now be treated. And that will be a much different world. One of the challenges will be to integrate all this information. So you can imagine it's not just grade PSA and perhaps MRI, but we're going to be in an environment where we have, of course, PSMA PET, results of urine and serum tests, genomic tests, biopsy results perhaps with tissue-based genetic assays, information about the patient's lifestyle and diet. How do you integrate all of that? And you integrate all of it with machine learning and artificial intelligence. So I think before long, we are going to have access to these programs that have data on tens of thousands of patients, and it will allow us to integrate all of this data in a way that it's very difficult for the human brain to do. So I think in 5 years, it's going to be a different world. I think we'll still have PSA, but there'll be a reflex test. I don't know which test it's going to be, and it might be one that we don't use yet, that will allow us to really identify which patients should go on to be imaged and then which cases should go on to a biopsy. And I think the goal is that almost all patients having a biopsy will turn out to have significant disease. So I hope you found that interesting. Thanks for your attention. I'd be happy to take questions.